Finally, let's discuss the topic of hypertension presenting to your casualty as or hypertensive emergencies, right? So this is the final part in the management of hypertension that we will touch. Hypertensive emergencies. Okay. By definition, what we imply by hypertensive emergency is a sudden rise in blood pressure. Okay. This sudden increase in blood pressure leads to a loss of the auto regulation of blood flow in many organs, and this causes organ damage. This is why we are always worried about hypertensive emergency. So, by definition, we call it a hypertensive emergency when you have a blood pressure of more than 180 systolic, or more specifically, more than 120 diastolic. If your blood pressure is markedly elevated, more than 180 systolic and 120 diastolic, then the question is there any organ damage ongoing? Why is this important? Because if there is organ damage involved, that is because of auto regulation, certain organs under high blood pressure are getting damaged directly. These organ damages should be corrected immediately, or you will lose an organ. What are these organ damages that I am talking about? If the patient has acute heart failure, acute coronary syndrome, aortic dissection, transient ischemic attack, a stroke, hypertensive encephalopathy, that is when there is increased intracranial tension because of the hypertension, producing vomiting, projectile vomiting, loss of consciousness. There are even acute kidney injury or glomerulonephritis can occur in these patients. Very interestingly, you can also have destruction of RBCs produced by microangiopathic hemolytic anemia. So it can involve the heart, the kidney, the eyes, the brain, or even there can be sudden onset of anemia. This is what we usually call end organ damage or target organ damage. Okay, so by definition, I'll leave it this way, that once your blood pressure is more than 180 systolic or more than 120 diastolic, and if there is no target organ damage, any of those that I discussed, you call it a hypertensive urgency. Okay. Now, newer terms basically call it elevated hypertension without organ damage. Now, this conditions, yes, the blood pressure needs to be brought back down to normal, but slowly. In patients who have hypertensive emergencies, okay, so these hypertensive emergencies are systolic blood pressure more than 180, diastolic more, or my diastolic more than 120, plus organ damage. That is, either you can see that there is some retinal problems, kidney problems, stroke, heart attack, transient ischemic attack, microangiopathic hemolytic anemia. These patients, you need to be very aggressive. Okay, how aggressive? We would want, in patients who have hypertensive emergency, that is with organ failure, you need to reduce the blood pressure by less than 25%. Okay, you need to bring the blood pressure down 25% within the first hour, bring it to less than 160 by 110 in 2 hours, and normalize it only within 1 to 2 days. In case of hypertensive urgency or asymptomatic but markedly elevated blood pressure, these patients, you can bring it to normal within days. So usually we just restart medications in patients who have hypertensive urgency. In hypertensive emergency, we need to aggressively give IV drugs to reduce the blood pressure. Okay, so to wrap up the management, hypertensive urgencies is when you would give the drug. Okay, there is no organ damage in these patients. You just say, okay, you missed your dose of amlodipine, you missed your dose of thiazide. Please take the medication. You should be fine. So no symptoms. Even if you have markedly elevated blood pressure, just give the tablets to the patient. Make sure that his blood pressure goes down. Ideally, even though you're going to just give the patient oral tablets, admit the patient to the hospital, monitor the blood pressure, because these patients can develop target organ damage, that is, can go on to hypertensive emergency. In any patient who is showing signs of organ damage, that is, any ischemic heart disease or heart failure, any evidence of a stroke or hypertensive encephalopathy, any evidence of kidney damage, any retinopathy signs, rapidly worsening visual problem, or even sudden onset of anemia. In these patients, you got to be aggressive. Reduce the blood pressure by 25% in the first hour, bring it to less than 160 by 110 within the second hour, and it should come back to normal within 1 to 2 days. So remember this, in hypertensive emergencies, you need to start IV drug therapy. Okay, what are the IV drugs that are preferred? Usually, we prefer nitroglycerin or levetolol. These are both injectable drugs. Okay, both nitroglycerin, which is started at 5 microgram per minute, and you gradually increase it, or labetalol 20 milligrams IV stat, or 40 milligrams given every 10 minute to a maximum of 300. You should monitor the heart rate in case of labetalol. Nitroglycerin can be used only for 24 hours, after that which the drug will develop some degree of tachyphylaxis. Remember, while you're giving these drugs for hypertensive emergencies, always start oral therapy. The idea is by the time the oral drugs work, you would be able to control the blood pressure and prevent target organ damage. All of these drugs are not to be given more than 24 hours. This is just for the emergency, right? To summarize our discussion on hypertension, we discussed about the definitions of hypertension, right? We also talked about conditions like white coat hypertension, what is masked hypertension, and how do we diagnose hypertension. It is not at a single reading, but you need multiple readings, at least a week apart. We also discussed what is the proper technique of measuring the blood pressure, and from there, we discussed the classification of hypertension into elevated blood pressure, stage 1 and stage 2 hypertension. We have seen how to manage elevated blood pressure. You just give diet and lifestyle modifications. Stage 1 hypertension, if the patient has less than 10% ASCVD risk, you just continue monitoring the patient, okay, every monthly till he becomes normal with just diet and lifestyle modifications. If the ASCVD risk is more than 10%, or if the patient is having stage 2 hypertension, you start on drug therapy, monitor every monthly till it becomes normal, and then follow every 3 to 6 months. Apart from this, we also discuss the management of secondary hypertension, how to suspect secondary hypertension, because in these patients you need to manage the underlying condition. We discussed the very interesting condition called resistant hypertension, where the patient does not seem to be responding to your medications. In these patients, usually look for some non-compliance or some underlying pathology. If you don't get that, there are newer drugs that you can add. Otherwise, you would have to go for baroreceptor stimulation or endovascular catheter based sympathetic denervation. We also discussed the concept of hypertensive emergencies, that is more than 180 systolic and more than 110 diastolic. When the patient presents in the emergency with target organ damage, you call it hypertensive emergency. Immediately, you will have to bring down the blood pressure. You start IV medications, right? The most important thing that you will take away from this series is, how do you diagnose, how do you measure, and how do you define hypertension, right? Management, you will gradually learn with practice, but with this you should understand that a single blood pressure reading can always be wrong. You need to have multiple blood pressure readings that show you that the patient is a hypertensive. I hope this discussion on hypertension has been informative and help you understand these concepts better. Uh, if you have any doubts on hypertension, please feel free to contact us on the number that will be provided in our website, or you can even go and send us a mail. While you're at it, you can also like and share our YouTube videos. You could also like us our Facebook and Instagram page and share it so that more of your friends can get to see our videos and interact with us. Right? So I would urge all of you to read up on hypertension from Harrison's textbook of internal medicine, now that you have all the time in the world. And if you have any doubts, please feel free to contact us. After all, we talk medicine here. This is Aram. Let's talk medicine. Thank you.